When to start vasopressors. Ricard Ferrer, Intensive Care Department, Vall d'Hebron University Hospital, Barcelona, Spain.
But how early you have to start the vasopressors? And the answer probably is early the better, because with vasopressors we can increase venous retort, we can increase preload, and also we can increase cardiac output. It's not only increase in blood pressure. So most of the studies are saying that simultaneous or in few hours after fluid administration, we can start with vasopressors. And specifically in those patients with low vascular tone, I mean low diastolic pressure, could be a risk to start very early in patients with high vascular tone and high diastolic pressure, because we can produce excessive vasoconstriction like in the right. And also remind you that also in the guidelines is mentioned that you can start the vasopressor by a peripheral line and then jump to a central line when the patient is already more stable. So this is a little bit of a paradigm shift that sure you have seen in your hospitals, that the patient received vasopressors very early, sometimes before ICU admission, when in the past was in the ICU where we provide the vasopressors, but not in the emergency department. Now it's patient receive fluids and vasopressors very early. You have seen before, I'm not going to stop here, that norepinephrine is the first line agent. You have seen the evidence, in this case in front of dopamine. So the guidelines again say that norepinephrine is the first line vasopressor, and the comparison with dopamine is high quality evidence, but the comparison with the other vasopressors are low quality evidence or very low quality evidence. But it's the first line vasopressors. When is too much norepinephrine? So this is the question for this session today, for the whole session of today. There is not a consensus in the literature. In fact, there is some confusion about when we are talking about norepinephrine base or we are talking about the salts, because in many papers this has not been disclosed, and also a confusion about which is harmful norepinephrine, which is refractory septic shock, and what is catecholamine resistant. So it seems that those concepts are very similar, but in fact they are saying different things. But at the end they are saying that my patient is not responding to norepinephrine, or I am producing HAMP if we keep pushing with norepinephrine, as has been alluded before. And the whole day we are going to speak about these slides, this DEC, then I skip the word, these DEC strategies that we have for today. First one is steroids. It's very clear from big randomized controlled trials that with steroids you decrease the amount of vasopressor and you decrease the duration of vasopressor. So again, for the guidelines, this is a weak recommendation, but with moderate certainty of evidence that intravenous hydrocortisone should be administered in patients with septic shock and vasopressors. And then the other strategies are going for a more multimodal approach to combine different vasopressors the same way that we are combining different drugs for controlling hypertension, using different drugs to for controlling shock. The most used second vasopressors, but the access is different in different areas of the world, is vasopressin. The effects at systemic level has been described in the previous session. Patients with sepsis maybe have a peak in vasopressin concentration at the beginning, but have a decrease later on. So supplemental vasopressin, it makes sense, have different actions which are all of them, in fact, very interesting, especially the kidney effects that has been described before. I don't want to tire you with additional info on that, but the effects on the kidney, because I mentioned the regional flow at the beginning, so it's not macrodynamics, it's also the flow between tissues. It's a different effect according to the tissue, so it could be an effect protecting the kidney, but in sepsis, from the VAS trial, another reminder, specifically in patients with less severity, it seems that can reduce mortality. It's a subgroup analysis, but it's sure that you can reduce the dose of norepinephrine. That can be a target itself. So you can reduce the dose of norepinephrine, and in patients with low severity, you can reduce mortality, and also you can have some protective effect in the kidney coming from the VANISH trial, specifically reducing the need of renal replacement therapy. This has been put together in many meta-analyses. I am out of time, so I'm going to skip this meta-analysis and going straight to the meta-analysis of the Sovereign Sepsis Campaign. The conclusions of the meta-analysis that it may reduce mortality, it did not reduce the need of renal replacement therapy in the meta-analysis, and there is not higher risk of ischemia or arrhythmia. So So this is the results of the meta-analysis we did for the surveillance sepsis campaign. Regarding cardiac output, there is no change in the VAS trial where in the patients that have Swan-Ganz catheter, no change, but in patients with low flow, there is an increase in the dose of dobutamine, saying that you have to be careful in that patient. So the suggestion, again, suggestion in the guidelines is to add vasopressin instead pushing up with norepinephrine, and the threshold is around 0.25, but I think this is going to be discussed in the next session. So again, the second vasopressor will come sooner than we are doing that in the past. If you want to visit the different phenotypes, this is the paper where we try to analyze the different phenotypes and how we are addressing this in my department. So conclusion, sepsis is a medical emergency. Vasodilatation, vasoplegia, and increase in edema is a landmark of endothelial dysfunction in sepsis. We need a personalized multimodal approach. We have to start vasopressor as soon as possible, keep mean arterial pressure around 65. First vasopressor in sepsis, but this is sure we're going to have discussion about that, is norepinephrine, but we have to combine with hydrocortisone and vasopressin when the dose of norepinephrine are going fast, specifically when really the trend is that the increase is really high. And we have, of course, lower risk of AKI and need of renal replacement therapy, but again, this is a topic for discussion. Thank you for your attention. Also, thank you for my team for helping me and, of course, replacing me when I am here.